Hello everyone, I am Dr. Trupti and you are watching my YouTube channel Enjoy Biochemistry. If you find the content on this channel useful, please subscribe, like and share the videos. In the previous video, we have discussed heme biosynthesis and its regulation, and in this video we are going to learn about disorders of heme synthesis, more specifically about porphyrias. Let's first revise the heme biosynthesis. It occurs in the erythropoietic cells of bone marrow and liver, and this process involves 8 important steps. The first step is condensation of succinyl-CoA and glycine to form delta-aminolevulinic acid. This reaction is catalyzed by the enzyme delta-aminolevulinic acid synthase, which is commonly called as ALA synthase or ALA synthase. This is the rate limiting enzyme and also it is a inducible enzyme of heme biosynthesis. And this step occurs in the mitochondria. Once delta ALA is synthesized, it is transported into the cytosol and then by the action of enzyme ALA dehydratase, two molecules of delta ALA they condense together to form porphobilinogen, that is PBG, and this reaction is catalyzed by enzyme ALA dehydratase, or it is also called as PBG synthase. Then 4 PBG molecules condense together to form hydroxymethylbilane, which is a linear tetrapyrrole, and this third reaction is catalyzed by the enzyme called as porphobilinogen deaminase or HMB synthase, and the third name is uroporphyrinogen 1 synthase. The fourth step is formation of uroporphyrinogen 3 from hydroxymethylbilane by the action of enzyme uroporphyrinogen 3 co-synthase. So if there is defect in the uroporphyrinogen 1 synthase, there is no conversion of porphobilinogen to hydroxymethylbilane, and that's why the precursors like PBG and delta ALA they are increased, and if the defect is in the uroporphyrinogen 3 co-synthase, there is no formation of uroporphyrinogen 3 and spontaneously this hydroxymethylbilane is converted to uroporphyrinogen 1, which is later oxidized to uroporphyrin 1, and again this uroporphyrinogen 1 is converted to coproporphyrinogen 1 and it is oxidized to coproporphyrin 1. The fifth step is conversion of uroporphyrinogen 3 to coproporphyrinogen 3 by the action of enzyme uroporphyrinogen decarboxylation reaction, and then by the action of enzyme coproporphyrinogen oxidase, coproporphyrinogen 3 is converted to protoporphyrinogen 9. This is the sixth reaction. In the seventh reaction, there is formation of protoporphyrin by protoporphyrinogen oxidase. And in the eighth reaction, that is the last reaction, iron is incorporated in the protoporphyrin by the action of enzyme ferrochelatase, and thus there is synthesis of hemes. Thus reaction number 6, 7 and 8, these reactions occur in the mitochondria. If there is any defect in the fifth reaction, the uroporphyrinogen is converted to uroporphyrin and it is excreted. So these are the various steps of heme biosynthesis. Now coming to the heme synthesis disorders, if there is defect in the first enzyme of heme biosynthesis, that is delta ALA synthase, it results in the sideroblastic anemia, which is X-linked. It is not included in porphyria. Second enzyme defect leads to ALA dehydratase deficient porphyria. It is due to defect in the enzyme ALA dehydratase. In this condition, delta ALA is not converted into porphobilinogen, so there will be increased accumulation of delta ALA, and this is responsible for neuropsychiatric symptoms and abdominal pain in condition of delta ALA dehydratase deficient porphyria. Then third enzyme defect results in acute intermittent porphyria. It is due to defect in the uroporphyrinogen 1 synthase. It is autosomal dominant condition. Then uroporphyrinogen 3 co-synthase defect leads to congenital erythropoietic porphyria. It is autosomal recessive condition. Uroporphyrinogen decarboxylase defect leads to Porphyria, Cutanea, Tarda, which is autosomal dominant condition. Then coproporphyrin oxygen defect leads to hereditary coproporphyria, which is also autosomal dominant. Variegate porphyria, autosomal dominant condition, results due to defect in the protoporphyrin oxidase. And the eighth enzyme of heme biosynthesis, that is ferrochelatase, if it is defective, it leads to protoporphyria. It is also called as hereditary or erythropoietic protoporphyria, and this is autosomal recessive condition. Now let's see the classification of heme biosynthesis disorders. These heme biosynthesis disorders can be genetic if there is mutation in the genes involved in the heme biosynthesis, and heme biosynthesis disorders can be acquired also. And this genetic disorder includes X-linked sideroblastic anemia if there is defect in the first enzyme of heme biosynthesis, that is ELA synthase. And other genetic disorders include porphyrias. So porphyrias do not include X-linked sideroblastic anemia. Now how these porphyrias are classified? The biochemical classification of porphyrias include hepatic porphyria, erythropoietic porphyria, and mixed porphyria, which has both hepatic and erythropoietic components. So there are three types of porphyria in case of biochemical classification. Hepatic porphyria is again classified into acute porphyria and chronic porphyria. This is the clinical classification. Now, which are the examples of acute porphyria which are presented with the acute attacks? The first one is aldehydatase deficient porphyria, acute intermittent porphyria, hereditary coproporphyria, and variegate porphyria. These are the acute hepatic porphyrias. Porphyria cutanea tarda, it is the chronic hepatic porphyria. It is a mixed type. It has both component hepatic and erythropoietic. Which are the examples of erythropoietic porphyria? It is congenital erythropoietic porphyria and erythropoietic protoporphyria. So erythropoietic porphyria means includes the name in the disease also. So it is very evident from the name that congenital erythropoietic porphyria and erythropoietic protoporphyria, they belong to erythropoietic porphyria. Now which are the acquired porphyrias or acquired heme biosynthesis disorders? So these can occur in chronic renal failure, malignancies, liver disease, lead mercury arsenic poisoning, and iron deficiency anemia. So these are the various heme biosynthesis disorders. Now coming to the biochemical basis of signs and symptoms seen in porphyria, and it depends on where the defect lies. If defect lies above the formation of hydroxymethylbilane, that is tetrapyrrole, then patient presents with neuropsychiatric symptoms and abdominal pain. So in this condition there will be increased accumulation of porphobilinogen and delta ALA. So exact mechanism of neuropsychiatric symptoms and abdominal pain is not clearly known, but it is believed that the porphobilinogen is neurotoxic and ELA causes oxidative damage to the CNS. Both ELA and PBG, they act on autonomic nervous system, resulting in the autonomic neuropathy. ELA inhibit ATPase enzyme and interferes in nerve and muscle conduction. So ultimately, because of the damage to the CNS, and as these are the neurotoxic compounds, the neuropsychiatric symptoms result in the patients of porphyrias, and these neuropsychiatric symptoms can be confusion, agitation, hallucination, anxiety, depression. It also results in various sensory and motor disturbances. For example, patient can present with pain in limbs, chest, neck, and weakness also. The another important characteristic feature, if the defect lies above the formation of hydroxymethylbilane, patient presents with abdominal pain, and this pain is not associated with inflammation. It is the neuropathic pain, which is also associated with vomiting and diarrhea. The restlessness, hypertension, sweating seen in the porphyrias is due to sympathetic overactivity. So if the defect in porphyria lies above the formation of tetrapyrrole, for example in condition of aldehydatase deficient porphyria, in acute intermittent porphyria, the patient presents with such neuropsychiatric symptoms and abdominal pain. Now, if the defect lies below the formation of hydroxymethylbilane, then there will be increased level of porphyrins, and these porphyrins will result in the photosensitivity, which is characterized by skin itching and blistering skin lesions. So there will be accumulation of porphyrinogen in the skin and tissues, and there will be spontaneous oxidation of these porphyrinogens to porphyrins, which is responsible for this photosensitivity and dermatitis. These porphyrins participate in the formation of superoxide radical from oxygen, and they are responsible for formation of reactive oxygen species. And these reactive oxygen species, they cause damage to the membranes, and because of that there is release of destructive enzymes from lysosome, and this is responsible for various skin manifestations and photosensitivity seen in the patients of porphyria. Laboratory tests of porphyria include detection of porphyrins and their precursors. UV fluorescence is the best technique, and all porphyrins will have an absorption band near 400 nanometer wavelength. It is called as SORAD band. Uroporphyrin, coproporphyrin, protoporphyrin, they show SORAD bands at 406, 400 and 408 nanometer wavelength respectively, and heme does not possess this property. So this is the technique for detection of porphyrins and to differentiate various types of porphyria. But the confirmatory test of porphyria is genetic testing, that is mutation analysis, and it is the confirmatory test of porphyrias. Coming to the treatment in porphyria in general. So the porphyrias can be induced by various precipitating factors. So the first management lies in avoidance of such precipitating factors. Which are those precipitating factors? This can be use of drugs like steroids, barbiturates, ethanol, antifungal drugs. So these drugs, they increase synthesis of cytochrome P450 for their metabolism, and we know that cytochrome P450 is heme requiring enzyme. So if for the metabolism of this drug there is increased formation of this cytochrome P450, so heme is utilized for the formation of this enzyme, and it leads to decrease heme level, and decreased heme level will induce ALA synthase 1 activity, and this can precipitate the attack of porphyria. So such drugs should be avoided in condition of porphyria. The other precipitating factor can be dieting, fasting or starvation. Now how this fasting and starvation precipitate the attack of porphyria? So it is seen that this fasting and starvation, it increases the formation of protein, that is proliferator activated receptor gamma coactivator 1 alpha, which is commonly known as PGC1 alpha in the liver. And in the fasting and starvation, this protein is responsible for increased gluconeogenesis in the liver, that is formation of glucose from non-carbohydrate precursors. So in starvation there is increased PGC1 alpha, which leads to increased gluconeogenesis in the liver. But in addition to increased gluconeogenesis, it is also powerful co-activator for transcription factors like NRF1 and FOXO1. So this is responsible for inducing delta ALA synthase 1 expression, and it further leads to increased risk of porphyria attack, and that's how fasting and starvation precipitates the attack of porphyria. And that's why in porphyria treatment includes the infusion of IV glucose. So when IV glucose is given, there will be no formation of this PGC1 alpha, which is responsible for formation of glucose, that is new glucose, by a process of gluconeogenesis. So when glucose is given to the patient, there will be no synthesis of this PGC1 alpha, and there will be no induction of expression of ALA synthase 1, and that's how porphyria attack can be managed. So that's why this is the biochemical basis how starvation precipitates the attack of porphyria, and why glucose is given to the patients of porphyria. In addition to this also, hemine is also given to patient intravenously, that is heme arginate, because it represses the synthesis of ALA synthase and decrease production of harmful heme precursors. Photosensitivity can be managed by beta carotene, which decrease the production of free radicals, and sunscreens. sunscreens are also advised. So this is the management modality of porphyria in general. Now let's see some salient features of acute intermittent porphyria. This acute intermittent porphyria, it is the autosomal dominant condition. It is most common acute hepatic porphyria and second most common porphyria. It occurs mostly in the females. It is due to defect in the uroporphyrinogen 1 synthase. So there is no formation of hydroxymethylbilane from porphobilinogen, and it leads to accumulation of or increased level of porphobilinogen and delta aminolevulinic acid, and it leads to clinical manifestations like neurological manifestations and abdominal pain. The biochemical basis has been already explained in the previous slides. Here in the case of acute intermittent porphyria, the symptoms starts after puberty and symptoms are intermittent. The symptoms are abdominal pain, neurological. There is no photosensitivity. Urine is colorless on voiding but darkens when exposed to light. It is due to photooxidation of porphobilinogen to porphobilins. There is presence of precipitating factors like steroids, barbiturates, ethanol, dieting, starvation and surgery. This can lead to this can precipitate the attack of acute intermittent porphyria. This condition is also associated with hyponatremia, and it can be due to syndrome of inappropriate ADS secretion or loss of sodium in case of this acute intermittent porphyria, because this is also associated with vomiting and diarrhea in addition to the abdominal pain. There is decreased deep tendon reflexes. Laboratory investigation shows increased PBG and delta LI in urine and plasma. The treatment options are symptomatic for the pain relief. IV hemine, IV glucose is given to the patient, and givosiran, that is also given by subcutaneous injection. So this givosiran is the hepatic targeted RNA interference therapy, and it is given to silence the expression of hepatic allosynthetase 1 messenger RNA. Now coming to the congenital erythropoietic porphyria, which occurs due to defect in the uroporphyrinogen 3 co-synthase. So there is no formation of uroporphyrinogen 3, and that's why hydroxymethylbilane is diverted spontaneously to formation of uroporphyrinogen 1 and then coproporphyrinogen 1, and which are later oxidized to form uroporphyrin 1 and coproporphyrin 1. That's why in such patients there is presence of uroporphyrin 1 and coproporphyrin 1 in their urine. So this is also called as the Gunther's disease. It is rare condition which is autosomal recessive. Defect lies in the uroporphyrinogen 3 co-synthase. Clinical features shows photosensitivity. There is repeated dermatitis, scarring and facial deformity can occur. So a monkey face can be seen in this condition. There is presence of erythrodontia. The teeth become red brown. Urine is port wine color. So these are the various clinical features. Laboratory investigation shows increased uro and coproporphyrin 1 in the urine. Porphyria cutanea tarda, it is due to defect in the uroporphyrinogen decarboxylase, and there is no formation of coproporphyrinogen 3 from uroporphyrinogen 3, and there will be increased formation of uroporphyrin 3 from uroporphyrinogen 3. So this is the most common type of porphyria. The defect is in the uroporphyrinogen decarboxylase. Clinical features are photosensitivity, photodermatitis, and there is increased uroporphyrin 3 in the urine. Now let's see some salient features of X-linked sideroblastic anemia. This is not included in porphyria, but it results due to the defect in first enzyme of heme biosynthesis, that is allosynthetase 2. This allosynthetase 2 is present in the erythropoietic cells. It is the genetic disorder. Defect lies in allosynthetase 2. It is manifested as anemia, and bone marrow produces ringed sideroblast rather than the healthy red blood cells. The clinical features seen are skin paleness, fatigue, dizziness, enlarged spleen and liver, and there is presence of sideroblast. Sideroblasts are the nucleated erythroblasts which are precursor to mature red blood cells, and they have granules of iron accumulated in the mitochondria surrounding the nucleus. Now let's see some important points about the porphyrias. First is acute intermittent porphyria. It is the hepatic porphyria due to defect in uroporphyrinogen 1 synthase. It is autosomal dominant condition, and the symptoms seen in such patients are abdominal pain, neuropsychiatric symptoms, but there will be no photosensitivity because there is no formation of porphyrins. The laboratory finding includes there will be increased ELA and PBG, and plasma porphyrins level is normal. So this is the acute intermittent porphyria. Second is congenital erythropoietic porphyria. So it is a type of erythropoietic porphyria. It occurs due to defect in uroporphyrinogen 3 co-synthase. It is autosomal recessive condition and it is associated with the photosensitivity. And laboratory finding shows presence of uroporphyrin 1 and coproporphyrin 1 in urine, plasma and RBCs. Then Porphyria cutanea tarda, which is the mixed type, both hepatic and erythropoietic. It occurs due to enzyme defect in the uroporphyrinogen decarboxylase. It is autosomal dominant condition associated with photosensitivity, and urine has uroporphyrins. Hereditary coproporphyria is hepatic type of porphyria. It occurs due to defect in the coproporphyrinogen oxidase. It is autosomal dominant condition. It is associated with abdominal pain, neuropsychiatric symptoms, also photosensitivity, and urine shows presence of coproporphyrin 3. Then variegate porphyria, which is a hepatic type of porphyria due to defect in the protoporphyrinogen oxidase. It is also autosomal dominant condition. The clinical features are abdominal pain, neuropsychiatric symptoms and photosensitivity, and urine also has presence of coproporphyrin 3. Hereditary protoporphyria, it is the erythropoietic porphyria due to the last enzyme of heme biosynthesis, that is ferrochelatase. It is also called as erythropoietic protoporphyria. It is autosomal recessive condition associated with photosensitivity, and here protoporphyrins are present in the RBC. So here you can see all conditions are associated with the photosensitivity except acute intermittent porphyria. And abdominal pain, neuropsychiatric symptoms, they are found in acute intermittent porphyria and other hepatic porphyrias like hereditary coproporphyria and variegate porphyria. Then Porphyria cutanea tarda is the most common porphyria, while the acute intermittent porphyria is most common acute hepatic porphyria. So in today's video, we have learnt about heme biosynthesis disorders, which include the genetic and acquired disorders, then the disorders like X-linked sideroblastic anemia and various hepatic erythropoietic porphyrias. So I hope this video on porphyrias will be useful to you. Thank you for watching and happy learning.